Hello, my name's Ruth Asprey, a women's health champion and health and wellbeing coach who also specialises in perimenopause and menopause, and I also run a corporate wellness business. In my spare time, I like to take part in endurance sports, that's swimming, cycling, running and avoiding leaks.
And I'm Lizzie, a clinical specialist physio in pelvic health. I run both an NHS and a private pelvic health clinic. I love what I do, absolutely love my patients, and I have first-hand experience of pelvic health issues as the proud owner of my very own prolapse.
Oh, I always think
You always say that.
Welcome to Oops, I Peed My Pants podcast that's here to break the silence, smash the stigma and get real about female incontinence and pelvic floor health. So listeners, ladies, we have a special guest on this evening. His name is Mr. Richard Peevor. He's a consultant gynaecologist and oncologist. He's a colleague of Lizzie, and we're very pleased to have him on. And we are going to be talking about his role, what he does, and also his fundraising and community work with Move Against Cancer. So,
Yeah.
on that note.
Yes, do you know, he does so much, he does do so much fundraising. He's brilliant. Pre-warning to the podcast. There is a little bit of sensitive content in there. So we do make reference to baby loss, trauma, and sexual violence. But anything that you might find triggering in this, we will put some resources in the show notes to help you after the episode.
Right, okay. Welcome. We have this evening, listeners, we have a very special guest, Mr. Richard Peevor, a consultant gynaecologist and oncologist. Thank you so much for joining us today. We know how much you love being outdoors, so we really appreciate giving up some glorious sunshine to chat with us.
Oh, it's a privilege. I'm excited to be with you. Yeah, it's good.
Thank you. So today we are focusing on the most important aspects of your work, your clinical role in supporting women through gynecological cancer diagnosis and treatments, and also your passionate involvement with Move Against Cancer, raising awareness and funds through the power of movement. So let's dive straight in. Lizzie, how are you?
All right, thanks.
Good.
I had a nice little run myself today. But anyway, right. So I digress in my running stories. So really nice to have you with us today, Richard. Can you tell our lovely listeners a bit about yourself and your, I suppose, your journey into medicine, how you came to specialise in gynae oncology?
Yeah, sure. So I'm like you up in North Wales. So I've been a consultant gynaecological oncologist for about 13 and a bit years now. But to get here, I've been all around the UK, from the Lake District originally, which is probably where my love of the mountains and the outdoors originates from. And then I trained in London, and then on the south coast, so Portsmouth, Southampton, Winchester, Basingstoke area. And then I moved to Cardiff for my gynae cancer research, which was into HPV and the association with cervical cancer. And I finished my sort of specialty training down in Cardiff, and then moved up here for my consultant job. So yeah, I've been up here 13 or so years. And my route into gynae cancer, well, I started off, and I am a consultant in obs and gynae, which is delivering the babies and general gynae problems. And it's sort of, people always think it's a funny specialty for blokes, but it's a sort of surgical specialty, and it's a really good specialty where most obs and gynae problems you can fix. And so gynae problems, people can come in with a symptom, and then you can usually do something medical or surgical to help them. So there's sort of good outcomes, I think. And then delivering babies, 999 times out of 1,000, that's a sort of happy experience, and it's really nice bringing babies into the world as well. So that's where my obs and gynae bit came from. And then I really like the surgical side and the complex surgery, and so gynae oncology surgery was a sort of the next step in surgery. So I decided to subspecialize in that and did some extra training to be a cancer surgeon. So now I've given up the babies and just do gynae and gynae cancer. And so I'm based in Bangor 4 days a week, with 1 day a week in Wrexham as well, on the North Wales coast.
So I just got a question, because just for our listeners, so we're all based in North Wales, and as a a health and wellbeing coach, over the last couple of years, I've had a particular interest, both from family and personal reasons, but also looking more broadly at society. Would you say that we've got and sorry to put you on the spot here, Richard, but have we got an issue with cancer across North Wales? Because the numbers that I look at, and I've been looking particularly at breast cancer, which are running at 33% in Denbighshire, and I think they're running at 25% in Conwy. They're pretty high anyway. Are you seeing an increase with cancer across the region?
I think it's hard to. We're quite a small region, North Wales. We've got a population of about 800,000 people, so we're suitable to have one cancer centre for gynae. Unfortunately I'm not up to speed with the breast and other cancers, but we have 3 cancer sites in Wales: Swansea, Cardiff, and North Wales. And UK gynae cancer is a relatively small specialty, but we do have deprivation in Wales, and so we've, on the index of deprivation, we're relatively poor regions, and so they do have a higher association with cancer.
Right.
We are seeing a rise in endometrial cancer, which is one of the gynae cancers to come on and talk about. And that's overtaken ovarian cancer now as the most common gynae cancer. But then we're seeing some cancers on the decline as well, cervical cancer being one. So it's a bit of a mixed picture. We're obviously challenged, as the rest of the UK is, with waiting times and cancer treatment times. But yeah, not huge shifts in cancer incidence at the moment.
Okay. So it's Gynae Cancer Awareness Month, so we want to, I suppose, educate our listeners on the 5 main types of gynae cancer, which obviously is your specialty. So can you give us a quick overview of what they are, and I suppose how they differ from each other? That'd be quite helpful.
Yeah, sure. So I mentioned one of them there, or 2 of them. So endometrial is now the most common gynae cancer, which is the cancer of the lining of the womb, which is the area of the womb which comes and goes every month when you have a period. But when that womb lining goes wrong, it can turn into precancer or cancer. I suppose key facts about endometrial cancer, if I maybe just go through the key facts of each one, and about them later on, is so endometrial cancer luckily generally presents as bleeding after the menopause, which for most women is quite an unusual experience, and so they know it's wrong and they go to their doctors relatively early. And so endometrial cancer tends to present early and hopefully is curable in a lot of people. But that is a cancer which is on the rise, and it's on the rise because of obesity. And so 80% or more of endometrial cancer is caused by obesity. And so that's
sorry to interrupt you there. 80% is caused by obesity.
Yeah, so
did I get that right?
There's 2 types of endometrial cancer: type 1 and type 2. And type 1 is sort of hormonally dependent, and those ones, when you're overweight, the fat tissues in the body produce excess estrogen, and the womb lining can thicken and become abnormal. So ladies maintaining a healthy normal weight have got a much lower incidence of womb cancer than someone who's overweight. So that's a real important factor. And
just before we move onto the other cancers, what's a normal weight?
I think people talk about BMI, and people sometimes argue about BMI, but for the majority of people, a BMI of 20 to 25 is a healthy weight. And yes, in rugby players, it might not be quite so accurate if they're solid muscle, but for the majority of people who have a normal body style, BMIs are pretty good calculator. And we're getting really sort of skewed into thinking overweight is normal. So often when we're operating on people with a body mass index of 30 who are overweight, we're actually thinking they're quite slim. And so the sort of we seem to be normalizing increased weight, which is also a bit of a concern. And quite often we're with womb cancer, we're often operating on morbidly obese people with body mass indexes of over 40 or even over 50 or even higher still.
It's a really high percentage, actually. I'm quite surprised by that. I really am. And it's obviously incredibly preventable, isn't it? So Anyway, right, so that's
Yeah, no, we'll come back to that.
Yeah.
Yeah, so that 80,
yeah.
that's a really that's, and I didn't realize that. I understand the different types of breast cancers, but I didn't realize there were two types, type 1 and type 2 endometrial. So I think there's a big, I think we could have a discussion just about that one on its own.
There's
Couldn't,
so much we
yeah.
could chat about.
Yeah, that's a part 2, Richard, I think.
I think,
Or part 3. Anyway, let's carry on. Yeah, let's
Yeah,
carry
carry on.
ovarian cancer used to be the most common gynae
Yeah.
cancer, now overtaken by endometrium. But ovary, I suppose most people would, if you ask the public about ovarian cancer, they'd think about late stage cancer. And sadly, the ovaries are two little organs in the body about the size of grapes, and they're hidden in the pelvis. And so ovaries have to get quite abnormal before they start to cause symptoms. And so often the cancer has grown and often spread, sadly, before the patients present. And when they do present, it's often with very vague symptoms, which can often be attributed to other things more commonly than ovarian cancer. So again, this is a cancer which tends to affect people after the menopause, but again, with endometrium and ovary, younger people can be affected as well. But with ovarian cancer, people are presenting with sort of change in bowel habit, feeling of bloatedness, loss of appetite, tummy pain, increasing girth of their needing bigger trousers and things, all of things which often get put down to bowel symptoms or irritable bowel syndrome, or just gaining weight with the menopause. And so again, that's probably the key fact for ovarian cancer. And then the other 3 cancers, we've got cervix, vulva, and vagina. And so cervix is the next common cancer. And the key message about that really is it's caused by human papillomavirus, or HPV. And we've now integrated testing for HPV into cervical screening, which is good. And more importantly now, for over a decade, we've been vaccinating children against HPV. So actually preventing the virus getting infection in the first place, and then preventing pre-cancer and cancer. So much so that the key message for cervical cancer is the WHO, the World Health Organization, are actually aiming to eradicate cervical cancer in our lifetime, which would be an amazing.
That's amazing.
Yeah, that'd be amazing. But I remember that BBC press release, because you did a thing on BBC, didn't you? Because there was so much bad media. Do you remember that, Ruth? About, I think the way the media presented it is that it was probably a cost-saving exercise, that your cervical screening went from 3 years to 5 years, and there's this great big uproar. But actually, in fact, it was because of the brilliant work that's been done around HPV and the cervical screening process.
Yeah.
So that we knew that if you're HPV negative, you're fine you're incredibly unlikely to develop it. I think it's within a 10-year period, isn't it? So 5 years is pretty amazing. But I remember that.
I definitely won't forget that. That was about 6 o'clock in the morning, sitting in my office in Bangor, getting nag and macheted on BBC Breakfast. So yeah, that's a moment I won't forget in a long time.
I know, yeah, but it is great. It's flipping good, because I mean, everybody hates having the smear test done, and I think we were saying this last time, weren't we? I entered into this bizarre, because HPV, like loads of people have HPV, don't they? It just comes and it goes. It's just this thing that's there. And I remember saying to the nurse, she's like, "We'll see you in 3 years," and I was like, "That, no, you won't. No, you won't. It's gonna be fine." And it's this like bizarre HPV competition, and I'm not really quite sure why. But anyway, then I was very smug when I came back. I was like, no, I don't have to have a smear for 5 years. I was just absolutely over the moon, because it's just really annoying, isn't it? But yeah, so it's great.
Yeah, I think I'm 5 years now, I think.
Okay, yeah.
Double check that. No, I'm pretty sure I'm 5 years.
But what I do still see, we did chat last time, didn't we, about patients that just don't like going for the smear test at all. And there's lots of, we're saying it's a whole thing on its own, but there's a lot of ladies my way that come my way that won't have the smear test done. And that can often be because of trauma, or they've had a negative experience with any kind of vagina examination, or that the skin or the tissue. You often find that in postmenopausal, even towards the end, like sort of 55, 60, when they're coming up to the last few smears, they can't go for the smear because it's so painful. So that is a little bit of an issue, isn't it? I don't know how often you see that in people presenting in your clinics.
Well, I think if they've presented, that's a great thing. I think the sad thing is when there's people out there who just aren't going for their smears full stop, and that's the problem is that we've got a fantastic call and recall system, in the UK, but the problem is once you don't come, you get a reminder, and then after that it just gets reset, to the next time that it's due, and so there's a whole cohort of people with services in the community just not attending for screening, and I think, and like you say, there's many causes of why they've come to find it challenging. Is it a previous bad experience? Is it previous sexual abuse? Is it you say, like say, skin changes and things? I think there's a huge amount of things we can help with, and some of the other things are just people having to take a day off of annual leave to go and have a screening test. That's another big thing, is that people just can't, or just don't want to go away from work, and work's not letting them have time off to go and have a doctor's appointment or a nurse appointment to have it done. So,
Yeah.
I mean, I completely understand that. I mean, I think I've spoken to you before about this, Lizzie. I didn't go for years because I had a negative experience with baby loss, and it was just so traumatic in a hospital in Surrey, and that had I mean, there was a lot of trauma around it, but I didn't feel comfortable. And even when I went for my because I had a post-menopausal bleed 2 years ago, and I had to go. And it was very quick. I mean, it was fine. I'm on HRT, so I think it was my progesterone levels, were bouncing all over. I think that's what the guy said. Anyway, I then said in the appointment, look, this is not something I feel comfortable with doing, and it's really does. So I understand how that can impact women. I really can understand. I think we're going to do a whole piece on this, aren't we, Lizzie, about
I think
trauma
so.
and thing, because I think it does. And then it's like you say, you miss one, and then you miss another one, and then before you know it, 10 years have gone by. And that's not, I know people go 10 years and go, well, yeah, because if you've traveled and you haven't had you haven't had a reminder. I mean, I lived abroad, so that's probably why I didn't, I wasn't in
think
this.
it's really important, because what we know is that if the people who get cervical cancer are people who either don't go for their screens at all, or for people who have had a gap between them. So if you extend the screening interval beyond the 5 years to 7 or 8 or 9, the risk really does shoot up. And just hearing you say that you felt empowered to sort of actually ask the clinician, say, look, I don't find this comfortable, that's brilliant. A lot of people don't have the confidence to say that, but I think that's one thing. That's the first thing you can do, is you can just tell the nurse or the doctor doing the screen, just say, look, I don't like this. This is always horrible for me. If you know what the problem is previously, you can sort of tell the clinician that. You can say, look, I've got sore skin, or I need if you know what size speculum you need. So if people use a small speculum or a longer speculum, it's always good to try and remember that, so that when you go next time, they don't try with a normal speculum as normal. You can say, oh, actually, no, I need a smaller speculum, or I need a longer one. And then you hopefully get it right first time. And, we've got things like double appointment slots for people who find it difficult. We've got the occasional people who like to put the speculum in themselves, actually. So, some ladies can manage to put the speculum in themselves, but can't have a practitioner do it. So there's quite a lot of things which we can help with. And so just telling the clinicians that you find screening difficult, and seeing what they can offer to make it better, and even referral into the hospital as well.
Oh, I think this is
can they do that then,
point.
Rick? Can they, if it's a troublesome smear and they just can't cope with it being done at the GP surgery, how would they then get into that secondary care? Would they go via gum clinic?
No, GPs or nurses can just do a referral into secondary care to Gynae. And I mean, it is sad at the moment with the waiting times for routine appointments being quite long, but we do have some clinics for sort of cervical problems, and so some of the waits for those clinics aren't quite as long. So, and actually, with it being a routine screen, it's better that we're able to sort of do it even if it's late, than not do it at all. And I think it's important to let people feel empowered about asking the nurse not to carry on. And I've heard some stories of where practitioners have tried for sort of half an hour to do a smear, and you just think,
Oh,
gosh, if you go more than 2 or 3 minutes, things
Yeah.
aren't heading in the right direction, really. So I'd
Mm.
encourage people, if they're finding it hard, is just to say stop. And because I think when you probably know, it's probably very similar to the things you're chatting about in physio, is that if you keep having bad experiences, it's just that vicious circle building up and up and up, and it just makes it
Yeah.
harder to break down and
Yeah.
reverse. So
Yeah,
And
absolutely. Well, I
where
think
can we find this info? Is this information sort of empowering yourself during an appointment? Is this on the NHS, or are there any other specialist web?
yeah, we had a fantastic cervical cancer charity, which I did some fundraising for, called Joe's
yeah.
Cervical Cancer Trust, and that was amazing. And they had so much information. I think the Eve Appeal, who I know,
I'm just saying the ones we're working with, the Eve Appeal. Yeah, okay.
They've got a PDF, haven't they? I think that I found,
yeah. So
which takes you through what Richard had said, and then also it's
Yeah.
got a check with me first thing, isn't it, for sexual or sexual abuse kind of patients. So if you go into that freeze thing,
Yeah,
where you
going to
might,
see.
when you're awful, isn't it?
Yeah.
Boys
Because quite
can't.
often women will
Yeah.
naturally go with their nervous system's naturally going to go into a freeze
Yeah.
state anyway, isn't it?
And
Even
you
if
can't verbalize it, so you can choose a
yeah.
signal or you just agree a signal. But yeah, it's brilliant. So we'll put that in the we'll put that in the show notes.
I will, yeah, we will.
Not the royal we.
We will actually put this in the show notes and do a little separate
Yeah.
post on social media. I mean, and as an aside, I think this is where with AI, this is where, getting people to the right information is going to become much easier
Yeah.
in
Yeah.
the very near future. So because I didn't know that information was available. Because when you go into the GPs, you go into the GP surgeries, and I mean, I was out of the country for 9 years, and so we always had to have private medical care in the UAE. So you'd go straight into a gynecologist. But when I came back here, I went into a GP service. And I still am a little bit surprised at the lack of information in the GP. And this isn't in any way to I'm not in the routine of bashing GPs at all, because I know it's just they're on the front line. They're just on the front line, but there's a lack of information. You always want to see the female body, don't you? You want to see that on the screen, like a little checklist, and say these are the things you need to ask, but we just don't see it, do we?
No.
Or am I missing it? Am I being a bit unfair?
No, I think because really, because we're coming into, Lizzie and I, from the health sector side, but
Yeah.
the public side, unless that practitioner actually provides it for you, you're not easily going to find it. I mean, yes, you can go and Google things to make the smear easier, and there is stuff online, and some people will obviously do that, but not everyone, sadly, So,
What about the schools?
Yeah, that's where we need to start, isn't it, really? They reckon we should
Yeah.
be educating them from about 12 years onwards. I did do actually. I had a brilliant COVID actually ruined my April Fool. I had a plan for an April Fool where I'd said to the kids, I'm coming in to do a sex education talk. And I was so excited about this April Fool. That was the plan. And then flipping COVID put pay to that, because it was April 2020. I was going to say, yeah, April the 5th. Oh, I'm coming in to do sex, like, just, let all the teachers know that you're going to like them. Honestly, I would have absolutely loved it. It would have been absolutely just the look on my kid's face. So, but anyway, yeah, we should be educating. So I was so excited, and it just got ruined. But yeah,
Right.
I don't think they have much education on stuff like that at school. Anyway, we digress.
Oh
Richard,
yeah, back to our
back to main
5.
cancer. Yeah.
So we've done 3 out of the 5, so endometrium, ovary, and cervix, and then we've got vulvar and vaginal cancer left. Vulval cancer, I think, is another really important cancer. It's a rare cancer, but this one is one that divides into 2, and half of vulval cancer is caused by HPV, the same as cervical cancer, and it's the same thing of HPV getting onto the skin and causing abnormalities. The other half comes from malignant change from a relatively benign skin condition called lichen sclerosis. So we get 2 different groups here actually, and the lichen sclerosis tends to be, again, postmenopausal ladies, whereas the vulval cancers tends to be a little bit earlier, sort of between sort of vulval cancer related to HPV tends to be sort of in the 30s to 40s, whereas cervical cancer tends to be a little bit younger than that still. And vulval cancer tends to present relatively early because patients notice a lump or changes on the skin. So thankfully they tend to get that checked early. But the sort of treatment is usually curative again, or hopefully curative. But again, quite disfiguring treatments for ladies. So, if you do even small operations on the vulva can change the anatomy significantly and obviously upset people greatly. So, and then vaginal cancer, the last cancer, incredibly rare, really, and it just is generally caused by HPV again, and it's usually an extension or next to the cervix, really, or just up near the cervical changes, and so it's probably not one to spend much time on today. I think it's rare to find it on its own.
So, but then all the time, so for those last 3 cancers, it's HPV, isn't it? Which really does bump up how important that cervical screening is, isn't it?
Yeah, and obviously now the HPV vaccination as well will hopefully prevent all of those cancers as well, which is really exciting. There's some data coming out of Scotland. They got started with vaccination early, like we did in Wales, and they've had I think I'm right in saying that there's been no cancers caused by HPV and people have been vaccinated so far. Obviously, they're quite young people still; they're only in their 20s, mid-20s, but it's still really exciting.
So is there anything,
isn't it? And just on that HPV, what's the age limit for the vaccination then? When do you vaccinate?
There's no age limit per se. The actual vaccination program is 12 to 13-year-old children.
Right, okay.
It started with girls, now it's boys and girls, because it's really important we vaccinate the boys because there's other cancers, there's head and neck, there's anal cancer. And also if you vaccinate the boys, if the girls aren't vaccinated, there's a bit of herd immunity as well, which reduces the chance of the girls getting it as well. It used to be 3 vaccines when we first got it, and then it went down to 2, and now it's only a single vaccine, which is really good. But even though it's a vaccine which is completely safe, there's really no risk. But unfortunately, the sort of uptake of the vaccine is really quite poor at the moment, and it's reducing sort of year on year. So it's only effective if people have the vaccine, and so it's really sad that people aren't having the vaccine. Going back to the age, you can have it later in life, but it's really a preventative vaccine, and so HPV comes with sexual relationships, and so really you need to get people vaccinated before they become sexually active, because otherwise you're kind of missing the boat, really. And so some people do have vaccinations in adulthood, but there potentially could be very little benefit from it, and so it's not recommended. So the actual recommendation is to vaccinate before you get exposed to the HPV as a child.
And is there any data on why they don't, why the uptake is so poor?
Yeah, that's what I was. Is that post-COVID, Stitch? Is that
it was actually dropping before that, really.
Right, okay.
I think one thing is probably because, look, I mean, it might be a bit of a victim of success of screening. Really, is that cervical cancer, in the 80s and 70s was a very, it was a well-known cancer. It was more common, and it was affecting young people, and advanced cervical cancer is horrible, and so there's a lot of emotion around that, and now actually it's rare, and so people don't have that knowledge of people who've had cervical cancer, and so I think it's, I wonder if some of it's that.
Well, I also, coming from the advertising world and the communication world, I also believe that we no longer have public information adverts, so you're not having those, we're not using mass media.
Like the old TV advert.
We're relying, so unfortunately, the way that the budgets are set up, it's, unless it was coded for a big nationwide issue, you tend not to see it, and we're reliant on, you're reliant on money from individual health boards, which I think is probably affecting a lot of stuff, because it's getting the messages are getting drowned out.
No,
that's not, there's no scientific basis there, but I get a feeling that with a lot of these things that that's the challenge that we've got, that that key things like, going back to that 80%, the impact of obesity, we're not able to get those messages out into the wider public as easily as we did back in the 80s and the 90s, when you had those public information broadcasts. Remember at News at 10? Do you remember that? The little things?
I love them all, yeah. But I suppose you have got social media, haven't you?
Decentralisation of all the budgets. Yeah, that's interesting, isn't it? It's a shame, given that it's all that work and it's a preventable cancer, and it's that the uptake is declining.
Yeah.
A lot of things have been looked at. So we're vaccinating in secondary school instead of primary school. That was to try and make sure people weren't thinking about vaccinating against a sexually, passed on infection to their very young primary school kids. So it was moved into secondary school right from the start. There was thoughts about religion, but actually,
I was going to ask about religion culturally.
Yeah, that actually was a big worry before vaccination started, and actually wasn't actually found to be anything of concern, really. So yeah, it's a strange one, and it's a shame, but I think there is work being done by public health bodies to try and improve vaccination, but we'll have to just see what happens.
You could become our first sexual health social media influencer, Mr. Peevor. That's what needs to be done, isn't it? You need some cool dude on TikTok or dressed up. Not
really
you.
not
I don't know.
So lowering the risk. So what can we? Because I'm a huge believer in. So what are the top 3 things a woman can do to reduce her risk of developing gynae cancer? Now, I know there are certain cancers, like you mentioned about ovarian cancer.
So I suppose, yeah.
What are your 3 things that you would like to see?
I suppose the easy one and the quick win, well, not the quick win, but it's the easy one is making sure your children go for their HPV vaccines at 12 to 13, boys and girls, and have those done, and then go for cervical screening, and however which way you do that. And so at 25, your first invite comes through, and just having them done on the 5-year intervals, and if you have an abnormal one, following the guidelines about that. So it's a quick win, although we mentioned earlier it's not nice going through cervical screening, but at least it's one thing that's relatively straightforward, and that basically reduces your risk and almost excludes, as we've said with vaccines, cervical and half of vulval cancer and vaginal cancer. So that's a really sort of good one. Then I think with ovarian cancer, it's the self-awareness, really, and just being aware of your body. And I think a lot of the public don't take kind of ownership of their health. I think they think it's down to the doctors to look after themselves, look after them. And so I think some education like these podcasts of just knowing about vague symptoms of ovarian cancer, so that if you're 55 and you've got new weight gain, new loss of appetite, new change in bowel habit, then you need to be seeing your doctor. And there is a blood test called the CA125, which is it's a sort of screening test. It's not particularly good, but it's a starting point, and it's a blood test which goes up with ovarian cancer. Now, I must say that it goes up with lots of other conditions, including benign conditions. So having a high CA125 does not mean you've got ovarian cancer. However, it's a starting point, and so the GP, the NICE guidelines suggest that if someone presents with new symptoms, like I've just mentioned, that the GP should do a CA125, and then if it's elevated, they should have an ultrasound scan arranged to check on the ovaries and the rest of the abdomen. And that's because it's what we're finding is a lot of ladies with advanced ovarian cancer, when you look back for the last 6 to 9 months, they've had maybe an endoscopy, they've had a colonoscopy, or they've tried diets, gluten-free diets, to try and sort out the symptoms, which is actually ovarian cancer, and perhaps if it had blood tests earlier or scans, then that could be have been picked up earlier. So I think sort of the only thing we can do for ovarian cancer is sort of awareness of symptoms, and educate the doctors, the GPs and nurse practitioners to sort of make sure they are following the guidelines of doing CA125 blood tests and scans where appropriate. And then I think my third thing really has to be about health and healthy living. And, you know, the world's becoming a bit of a scary place with you know, diet and food and weight gain, and we're seeing so many medical conditions caused by obesity, and also a normalization of obesity in the public as well. You know, people feel that being overweight is normal, and you know, in America, you know, those figures, and we're not far behind, but you know, 50% of people in obesity in America and things like that is pretty scary stuff.
Yeah.
So I think,
yeah, I mean, that whole self-awareness and healthy living, I mean, it's something that Lizzie and I have discussed at length, haven't we, Lizzie, both on and off, on and off the podcast, and you know, and the whole piece around body positivity, which I completely get, and I'm not saying that, you know, it was wrong in any way, but I do question, and this is only this is completely my personal opinion, having worked with women for the last few years, and it's been one of the most, working in the wellbeing space has been one of the most challenging things I've ever done in my life, because to, you know, encourage, to support women to change behavior is like, and I get that women are busy, and I get that women are under this huge amount of pressure, and there's a lot of emotional stuff tied up, but what I think the thing that really bugs me, and Lizzie knows this because she's on the brunt of it, when I say, look at this, what I've just seen on social media, look at this, somebody's criticizing a GP because their BMI is 40 and it's a patriarchal system, because how dare they question her body size, and all women, which I, you know, yes, all women are beautiful, we're all beautiful, we can all choose. However, if your BMI is high, then you're at higher risk. And so it's a real challenge we're facing at the moment, because it's very difficult. It must be, it's so difficult for you guys working on the front line, but it's very, very, very difficult to challenge that conversation at the moment. And I'm a believer we do need to start to have that conversation. It's a hard conversation. And my sister and I say, you know, we have to choose hard. And that's not about being hard in terms of how you support a woman. It's about, you know, hard is getting up in the morning, moving your body. Hard is choose, you know, those little things, isn't it? It's hard to get up and go for a walk when there's nice TV on. You know, we've become soft, she said.
it's scary. I mean, I
Scary.
can't talk about patients, but I had one patient recently who, often in letters we put like a list of problems at the top, and we had a list of problems, which is obesity, polycystic ovarian syndrome, dyslipidemia, which is lipid problems, insulin resistance, and type 2 diabetes, sleep apnea, and then chronic fatigue syndrome. And if you normalize the weight, all of those would, well, most of that, you know, nearly all of that would be so much better, if not all fully solved. And so I think it's quite exciting with sort of it'll be interesting to see what comes of the new sort of weight loss injections, and then
Yes, I think they will help, and I've certainly spoken to a number of women who've had, but they've been on them for a couple of months and then come off, and then are now they've made those shifts to healthy living, so they've used them as a bridge rather than the solution long term. And I think that's the key thing. If you can get women to, you know, if you can get them over the hill, it's like the HRT debate in many ways, isn't it? I mean, I'm on this Facebook group, and it's called Menopause and HRT. And honestly, did you join it, Lizzie, on Facebook? There's about 50.
Yes, you know what, I'm terrible.
Oh my God, I just want to go in there and you know, and they're saying, oh, I've got to have 4 pumps, this pumps, and you know, you'll get one woman saying, well, are you drinking alcohol? Are you moving? you know, have you made those lifestyle shifts? That HRT is not going to fix you. And it's the same. My worry about the weight loss injections is that women are jumping to them as the quick fix solution, and but they're not going to be the quick fix solution, because you've got to make those changes as well. So it's hard to get that message out there.
Without that, I mean, I've had the patients that I see with them it's an absolute lifesaver, and they've come back and gone, God, I feel so much better. So I think it is a really good interim, because they've tried every diet, they've tried, and it's so, we always argue about this because it's so complex. I do agree, but it's so complex. It's as much of a mental health issue as, say, bulimia or anorexia, but I think I am a strong believer in that. I don't think we've got enough support systems for them. So it's all very well saying, can you go and do that, please? But we need a really robust, lots and lots of resources and lots of ways we can hold people's hand to help do that, really. That's where we need to pour money in, isn't it, really? We've got some resources, but I don't know why, it's just really hard for ladies. And certainly it's a big challenge for me in sort of physio. You've got to, it's never the first thing that I broach with people, because I want them to be on my team, I want them to work together, and there's also a lot of other things that they can do first. That is the hardest thing, and trying to find a way to support them is so desperately hard, and they'll have tried everything, absolutely everything. So but anyway, yeah, which does move us nicely into Move Against Cancer and your 5K My Way. So you can tell us all about that. Have to stop, Ruth.
Yeah, it's something I got involved with last year, actually, and yeah, I just saw it advertised, actually, as a sort of in the hospital, actually. There was a banner, and it was actually advertising an event on Anglesey in Nancy Pandy Park Run, and it's a sort of, it's a directive called 5K Your Way, and it's linked to Park Run, and that has its own challenges, which I'll come on to, because I think the run bit in Park Run is quite scary for people, and the fact there's lots of people in Lycra and running clubs running very quickly. There's a big drive at the moment from Park Run and to have Park Walk, and people have been welcome to walk all the time at Park Run, but they're actually branding it as Park Walk as well now, to try and encourage people to come and just move and walk, which is really exciting. But essentially, 5K Your Way is actually linked into a charity called Move Against Cancer, and this is about helping people who are on the cancer pathway, either during diagnosis, during treatment, or afterwards, or their families and friends. And the Move Against Cancer charity does have some one-to-one counselling sessions and some online resources. But one thing that's really come out of it, it was started by an oncologist in Manchester, this 5K Your Way group. And this is about having a group of people who are interested in facilitating people who want to come along, and once a month, so it's not every week like Park Run is, it's the last Saturday in every month, and only at certain park runs, because it's expanding, but it's regional at the moment. And so, for example, in North Wales we've got 4 Move Against Cancer 5K Your Way groups, and what that is there's a number of ambassadors in each group. I'm the lead ambassador for Conwy, and I've got a team of ambassadors with me who are people who have been through cancer treatment. Got some specialist nurses, and they're there just to help people chat. And it's so lovely. What we've got is, so people come along, we advertise it on Facebook in our own groups, 5K Your Way in our regions, and people come along. We've gone from a few people to up to, I think we had 28 people come last month, and it's really lovely to hear our ambassadors talking to them, or even just helping each other out, talking about their cancer journey, and talking about radiotherapy, talking about chemo, talking about hair loss, and using cold caps to prevent their hair loss, and just chatting. And as I walk around between each little group of people on the course, it's great to hear hear them chatting. And the idea of this is that you're just out for a movement and a chat, and we sort of do the 5k at Park Run, and then we go for a coffee afterwards for a chat. And the other thing that's a misnomer is the 5k bit. With the 5k Your Way charity, there's no need to do the whole 5k. So if people are going through treatment and don't feel able to walk 5k, you can just do 1k, 2k, 3k, whatever, no k's, just come for a coffee. But actually, amazingly, nearly everyone, I think, has done the whole 5k for us, actually, in our groups each month. Because I think when people do get chatting, they just get walking and carry on. We're walking at an hour and 10 minutes. So, whatever everyone's pace is. We've had some people run it as well. So it's just a really good space, really feel good vibe once a month. And then because it's linked to Park Run as well, as that, I volunteer at Park Run each week, and I wear my 5k Your Way hoodie each week. So if people do want to come on other weeks and chat informally, then we're also there as well. So hopefully this is something that's going to expand and spread across more park runs over time as the charity grows. We've got to be careful not to push. I think charities have really struggled lately, and so I think they've got to be careful to expand in a way that they can deliver long-term success and not just overstretch themselves. But there's one, you don't have to drive far to find a 5k Your Way in England or Wales. Scotland's got a few more gaps, but it's coming. So it's really exciting, and I encourage people to do it. And I think in the health service, there's been a real sort of tradition for people to say, oh, you need 6 weeks off. You're not allowed to, you can't do anything when you're recovering from your operation. And it's rubbish, There's hardly any evidence for any of this. And one of our ambassadors made a pledge that she was going to move every day during her cancer treatment for breast cancer, so surgery, chemo, radiotherapy. And she did. She was cycling on a turbo trainer in her garage. She was walking. She was running whenever she could. And she did have difficult days where she really didn't do very much. But she still made the effort to get out and do something. And I think it's those sort of people who can really help other people and say, look, you're not unwell as such. Obviously you're going through a lot of things, but you can still move, and I think the body can always surprise us, and we can often do a lot more than we think we can do.
Yeah,
absolutely. There's a brilliant, I love that idea, and I know a couple of people that have been through. One lady's been through ovarian cancer, and she treated it as a race, going through each cycle, and she was still riding her bike and being active for the full year. And yeah, she had low points, but she was amazing. So, and I think getting out and moving your body just switches your mindset, doesn't it? The worst thing you can do, I think, even when you're fit and healthy, is sit on the sofa. God, I would be if I sat on the sofa.
well, that's it, isn't it? Sit on the sofa, crisps come out, the wine comes out. It doesn't know.
Sofa all day.
Yeah.
It just kills you. I love that idea. There's another fantastic app called Her Spirit, which is for women, but it was set up. They do a lot of work with breast cancer now, and they support women to get moving through breast cancer, and it's fantastic. The power of movement.
But also, it reduces the risk of recurrence as well in a lot of cancers as well. I know we're getting off the gynae cancer, but certainly bowel cancer and things like that, it massively reduces the recurrence of it. So but yeah, it's that 5k Your Way sounds like a nice, it's like a support network as well, isn't it? I bet
when is the next one? When are you finishing your fundraising, Lizzie? When is it? 31st of May?
Yeah.
Yeah, it is. Yeah. I feel like finishing it today after my little fall into the lake.
Come on now.
Yeah, 31st of May. So it's the last Thursday, but no, not last Thursday. Last Saturday of the month, isn't it?
Yeah.
When's the 31st? I know quite a few. I know lots of women, unfortunately, that have been through it. Well, unfortunately they're out the other side, and they've often struggled post-treatment to get support. That's where they seem to, and it's been just like exercise and finding the right class has been a lifesaver for them.
I think the good thing about our group is that our groups is that it's not related to gynae cancer, it's any cancer. So
any cancers, right?
And also I think certainly in our group, we've got a lot of specialist nurses and myself, and
Yeah.
hopefully signpost people as well. If it's not part of our role, we haven't got any education from the charity in regards to that. It is just about a group of people to have a bit of peer-to-peer support. But
Yeah.
by the nature of the ambassadors is we can definitely help people, signpost them and give them medical support if needed as well, and encouragement. And I'd really like it to develop. I'd really like to have people moving on from this once a month, because once a month, yeah, it's great to move, but it'd be great to have people coming down every Saturday to their local park run just for a walk and a coffee afterwards, and then hopefully you get some of these people feeling like turning from walking into running as well, and just getting moving as well a bit more. So it's a work in progress for me, that, but hopefully, I think with endometrial cancer, one exciting thing, which again I haven't had time to do yet, but it's a teachable moment in that we're curing most of our endometrial cancers at stage 1, and ladies whose body mass index is 40 or 50, it could almost be a teachable moment where you say, yeah, we've cured your cancer, but now let's see if we can try and reduce the weight, get healthy, reduce the cardiovascular risk for the future, and all the other risks that come with obesity, and see if we can get people living better and feeling better about themselves following cancer treatment.
Yeah, I like that thought, that teachable moment, thought of movement. I
did want to ask you about, in terms of that post-cancer support. You were saying last time there was they're opening a Maggie Centre in North Wales. Can you give us a little ditty about that? That'd be brilliant.
I think the NHS as a whole provides really good cancer care, but unfortunately, what it doesn't tend to do is the sort of bells and whistles of cancer care, and so we do rely on the third sector, which is a sort of posh term for charities, and Maggie Centre is completely a charity. It's around the UK, and these are centres, again, not specific for gynae cancer, just for anyone going through cancer treatment, and they're buildings which are close to the acute hospitals, and they're usually lovely buildings, really well designed, airy space, and they're a piece of sort of an area where people can go for a bit of quiet and solace to get support, but away from the hospital. And so it's based around a kitchen table, and so big kitchen table, and go in and have a coffee and a cup of tea and a chat, and it's supported by volunteers, trained volunteers, and there's that sort of social aspect, but then there's a lot of classes that they put on for helping with everything about living and dealing with cancer diagnoses. So about counselling, finance, helping fill out forms for support, financial payments, helping with massage and makeup sessions to try and make people feel better, yoga, wellness things, just so much going on in there. And there's there's 2 in South Wales, there's Cardiff and Swansea, but in our cancer centre in North Wales we haven't had one, so the only one was in Liverpool in the Wirral, and so people wouldn't really go there after treatment, but it's one's being built in Glenclwyd Hospital, which is our sort of North Wales Cancer Treatment Centre, where people have radiotherapy, and so we're getting our first Maggie Centre in North Wales. So they've had their topping out ceremony, so the building's built now, and it's just being sort of fitted out, and with a view to it opening in the autumn. So that's going to be really exciting.
Yeah, that'd be absolutely brilliant.
Fantastic.
Yeah.
So Lizzie, are you going to ask the lighter question?
Well, I did think I would say you've done lots of fundraising, and rather
you
than
don't have to answer this, Richard.
Yeah, no, I was going to say this is quite a nice one, is it? Any standout moments or emotional highlights you'd like to share, or even better, some kind of hideously embarrassing story involving yourself would really make me happy. It's fine. There's no pressure.
I haven't got anything horrendous, but I think last year I sort of hiked around or jogged around Anglesey, mainly fast walking, which is 210 kilometres. So I did 50k days back to back to get around Anglesey in 4 days around the coastal path. And it was Easter weekend, and I did it for Maggie Centre. for North Wales, and the amount of people from the hospital who turned out on the bank holiday weekend, even some people who'd been to church on Easter Sunday, then came and found me on the coastal path. It was so lovely, and to have about, I can't remember, 30 or 40 people waiting for me in the Arms when we finished in Menai Bridge, it was amazing. So, and that raised over sort of £7,000. So just the support that people gave me last year was amazing. Funny moments. I think Simon and I, my colleague, there's two of us as cancer surgeons previously, before my colleague Ms. Ros Jones joined, but Simon and I, we did some fundraising, and we did Holyhead to Chester bike ride, and then we did Conwy to Cardiff as two different projects for the Joe's Cervical Cancer Trust. And I remember, I'm not a cyclist at all, I'm a runner rather than a cyclist, and so I did Holyhead to Chester on no training, and we got from Holyhead to Colwyn Bay, where we both live near, on the first night. And when I woke up the next morning, I had 4 butt cheeks. I had these 2 swellings that I've never seen before on my bottom, and I was like, how on earth am I going to ride another 50 miles from Colwyn Bay to Chester? And I think it was like extra padding, really. It was like a second paddle. But oh my God, that was weird.
Do you not have any pet? Did you remember? This is, you don't.
Yeah, I did.
I was just thinking, Holyhead to Colwyn. That's not that far.
Yeah, but I don't cycle.
I'm just showing off then, because I'm a cyclist, but that is actually quite far, actually. Holyhead
50 miles times 2, and I'm not a cyclist at all. And yeah, I had padded shorts, I had chamois cream, but it wasn't. Something wasn't. I could have ran it more easily than I cycled it, to be honest.
Oh, it's painful.
Painful. Well, Richard, thank you so much for sharing this really useful information, and for your time.
I just get one last thing in.
Oh yeah, go on.
I think we just might have skipped a little question, which I know we shouldn't really say we've got a script, but we've skipped one little question which is important, which is about new developments, and it comes on to our difficulties with cervical screening. And I'd really like to get this plug in, because
go on then. Yes, of course. Yes, sorry.
There is that group of people who really don't want to attend for cervical screening, and my registrar at the moment, Jen Davis, she's just finished a PhD in Manchester doing research into HPV, and her PhD is about urine testing. And it's really exciting work where people can have just a simple urine test, just like looking for an infection, but actually trying to pick up HPV. And there's a clinical trial, which we can put the details in the show notes, that people can self-refer for. So if you're over 6 months overdue for your screening test, you can actually join this trial and have a urine test. And what that does is, if you're HPV negative, it's very reassuring that your cervix is probably completely normal. But if it's positive, then it's just that additional encouragement to say that really you should try and make the effort to go for your screening test, and we can try and help you on the way. So if I could maybe give you the link to that trial, that would be a really good resource for anyone who's thought about that whilst listening to this podcast, and they can actually just contact the trial online and get a urine test sent out to them at home. So
and that's how they can take part in the trial then. They can literally just buy. Oh right, yeah, no, that's fantastic. Yes.
They've got to be overdue, haven't they? Is that right?
Overdue, I think.
Yeah.
Well, I get a gold star because I gave that link out yesterday.
Ah, well done.
So, but actually, it was really useful, and I've got a few more people coming in next week that I've earmarked and gone, right, I know you're overdue, because that's partly what we're working through treatment-wise. Going, right, okay, the goal of this treatment at the end of it is to be able to get you to cope with the speculum exam. So they're going to get it done, so well overdue. And that, yeah, it was amazing. And actually, the lady that I gave it to yesterday was absolutely overjoyed, because I think she probably can go for a smear, but just completely dreads the whole thing. And I said, well, this is it. If you get that, and it's, I mean, I still really want you to go for a smear, but if you get this and you get a positive result from it, she said, yeah, I think I probably would be a bit more likely to just go for the smear. So it's, yeah, brilliant. Yeah, amazing. That's so exciting. Yeah.
So that's great.
Fab. Thanks so much for your time.
Pleasure.
Thank you very much. Yes, thank you very much for your time. You will be getting an invite back. There's a lot more. We'll do one all around
Global disease. I think
Yeah,
we'll-
We'll do one around the move for cancer. I think we could do a specific one around that. I think there's a lot to be done there in terms of promotion and getting people involved in that, especially across the region. So so we'll get our thinking caps on around that, around how we can support that moving forwards and towards the next half of the year. So thank you so much. Fantastic, so much to impact, and there's so much great work being done, isn't there? There's so much brilliant research being done. There's so much stuff we can do, and there's so much prevention work being done. It's just great. It really is. We just gotta get that 80% number down. Great, thank you, Richard.
Pleasure.
Thank you, you're
Anytime.
legends. Thank you very much.
So listeners, don't forget, all the notes will be in the show note below, and if you've got any concerns, then pick up the phone tomorrow, talk to your GP, book your screenings, and let's spread the word. Thank you.